Hey everybody, this is going to be Clinical Pearls Mastering Advanced Hemodynamics. Objectives: we're going to discuss case scenarios that apply to hemodynamic monitoring. We're going to look at a concept called the 1 to 5 rule, discuss the different shock states, and analyze advanced hemodynamic impacts related to different pathophysiology. Let's start off with a review of our pulmonary artery catheter, or what we call the Swan-Ganz catheter, named after Dr. Swan and Dr. Ganz. This is an invasive line usually put in the subclavian or the IJ, most often probably placed more on the right side than the left side, just an easy way of accessing that right side of the heart and the superior vena cava. When we look specifically at this catheter and we review really how we would use this in transport, we're not seeing a lot of these in transport like we used to. I think that is definitely changed over the years, but you could definitely see these. When we look really at the catheter itself, I think the big thing you always want to focus on when you see these patients is identify that the catheter has a syringe with it. That syringe usually should be attached to our balloon lumen, and that's this port here. But the first port we always want to identify is our distal port. That distal port, if we were to do anything with this distal port, it actually would transduce down at the PA distal lumen, and that's where we see this area here. And really the two things that you use that distal port for would be, number one, to transduce your pulmonary artery waveform based simply off of our pressure monitoring system, right? So your bag of saline, your pressure tubing, and that's what's giving you that waveform. And then secondly, it would be to draw an SVO2, but we would never push fluids, push medications through that port. Where you would do that would be your proximal injectate, proximal infusion ports, and that's these two ports up here. Those are essentially a fancy central line, and so anything you do here, they're going to drop into that central circulation, the superior vena cava, right atrium area. And that's actually where you could also see thermodilation of the CVP with a separate system. Again, another monitoring system, pressure bag, normal saline, and pressure tubing. And so you could have a CVP and a pulmonary artery systolic and diastolic. Really, from the standpoint of our inducer, this is most commonly 7 or 8 French, placed in a cordis, obviously. There is a protective sheath over the top. A lot of people call it a swandum, again, to maintain that sterile environment. We obviously have the balloon at the very distal tip, and that balloon is going to be inflated or deflated for wedging purposes only, based on that balloon lumen. Again, that's our red port. But really, from the standpoint of pulmonary capillary wedge pressures, there's really no reason for us to ever wedge a catheter in transport. And really, the most progressive ICUs in the nation do not wedge catheters. Maybe initially, they might do it initially on insertion, most definitely with the physician that's placing that. But really, from a nursing side, there might be one wedge initially, but you can easily just identify a wedge based on your pulmonary artery diastolic pressure, subtracting 2 to 4 millimeters of mercury, and that's going to give you a great representation of what a true wedge is. So you're seeing less and less of wedging those catheters. And so for that example, you don't need to wedge these in transport. I think that is definitely something that we do not need to be doing, and we can definitely glean the same information by looking at that diastolic pressure off of the PA. If we evaluate our shock states, again, just for a quick review, we have multiple different types of shocks, and we'll start off with our obstructive shocks. And these are shocks essentially that I always think of as limiting or stopping our blood flow to the point where we have a depressed or decreased cardiac output. So think about life threats like cardiac tamponade, tension pneumos, massive saddle emboli, big PEs, and then obviously in that neonate population, some of those outflow obstruction heart defects like hypoplastic left heart, coarctation, and so that's going to be a congenital disease process. When we look at cardiogenic shock-related cardiomyopathies, that's where we're going to see primarily a left ventricular dysfunction. And most often where you're going to really see this is in a dilated cardiomyopathy. And these diastolic failures that start happening. So you can have either a systolic, which would be a dilated cardiomyopathy, or you can have a restrictive cardiomyopathy that is essentially that diastolic failure, which causes a high left ventricular end diastolic pressure and a high SVR. And so your cardiac output is significantly decreased because the left ventricle cannot contract against those high SVRs. It's restricted. Its inotropy is limited. Frank-Starling curve is significantly reduced. When we look at distributive shocks, always think of third spacing that volume. That volume is not in the right location. So we think about sepsis. We think about anaphylaxis. Hypovolemic shock specifically, a lot of people that do a lot of advanced hemodynamics don't really consider hypovolemic shock a type of shock because essentially this is just a volume loss based on hemorrhage. It could be volume loss based on sweating or free water loss, and obviously loss of fluid content in burn patients. When we think about neurogenic shock specifically, these are going to be a patient with a sympathetic transection of that nervous system based on wherever that injury location is. And, that's where we're going to see a parasympathetic dominant patient. Really, when you look at these patients from a standpoint of assessment, we did a module on spinal cord injuries, and I talked specifically about neurogenic shock versus spinal shock and the differences and what you're going to see on that initial assessment. And a lot of times, really, when we teach this very loosely. You're going to most likely see a patient that is hypotensive, but you don't always see an initial response like you read in the textbooks of bradycardia. So we got to make sure we understand we have a big, massive container failure. The volume is just not enough now in that large container, so we have to fill that volume. We need to start vasopressor therapy early. And so anyway, we really get into that in depth in our spinal cord injury podcast and overall module. And then our last one is called a dissociative shock, and that is a shock related to, our metabolic related issues. So you have carbon monoxide poisoning, methemoglobinemia, those toxic metabolites. We, really look at the acronym GOLDMARK, and you can go through ethylene glycol toxicity, propylene glycol toxicity, Tylenol toxicity related to oxyproline. And we get through all of that, and that's where you really start having to look at our acid-base disorders. If we review our advanced hemodynamic numbers, first starting with our SVR, remember SVR is our systemic vascular resistance and our ability to really compensate. And you can calculate that by identifying your MAP, calculating that MAP, subtracting it from a CVP, divided by your cardiac output, and you multiply that by 80. And we know a normal SVR is 800 to 1200 dynes per second. And then we look at the right side of the heart. We have our pulmonary vascular resistance, and that's going to be, a little bit more complex from a calculation standpoint, but we know that really is a resistance that our right ventricle has to contract against. And we have a much lower normal PVR of 100 to 200 dynes per second. And then when we look at cardiac output is 4 to 8 liters per minute. But remember, in the ICU, you're going to use an index. That index is cardiac output divided by body surface area, and that is half of your cardiac output. So the way I always remember this is my normal minute ventilation for my patient is 4 to 8 liters per minute. I know that we want equality in our lungs. So I remember my cardiac output is exactly the same range at 4 to 8. And then my index is half of my cardiac output. So you just take both those numbers and divide them by 2, and that's your cardiac index. And so that's a great way to remember those ranges. We have to also understand really our stroke volume and the importance of stroke volume. We have our heart rate. So heart rate multiplied by stroke volume equals our cardiac output. And heart rate, I think, is very easy to understand. Is it tachycardic based on compensation, Are we bradycardic based on a patient's inability to compensate? Are they on a medication that is limiting that? Or are they young, right? Are they an athlete? Are they somebody that really takes good care of themselves and has a very low standing heart rate? Are they pediatrics versus elderly? So lots of different factors that play into our overall ability to compensate. But really, the stroke volume side is a little bit more complex, and that's where we get into preload. Preload is the volume entering into the right side or our inferior superior vena cava feeding into our right atrium. And so what's our volume status essentially? Our afterload is going to be, what is that left ventricular end diastolic pressure? What's the pressure at the end of diastole in that left ventricle? And that is very, very important. And that is driven off of a good optimized preload, obviously. And then what is our ventricle's ability to contract? Do we have normal contractility? Do we have diseased ventricular responses based on long-standing hypertension? Do we have a diseased right ventricle based on, cor pulmonale or, COPD, these right-sided lung issues that have now caused a stiff ventricle? And is that impeding and causing a poor afterload? Is your left ventricle then also inhibited, or do you have just an isolated left ventricular systolic or diastolic problem limiting contractility? So ultimately, we have the ability to recognize preload, afterload contractility, and we have medications and strategies around optimizing each one of these. Really, the focus of this talk is to really take us through cases so we can evaluate our advanced hemodynamic numbers as it relates to our blood pressure and look at these patients and understand how we can treat these patients accordingly. So what does the 1 to 5 rule tell us? Essentially, it gives us a great ability to evaluate the heart. Is the heart in a place where it's not overly filled, but still able to generate a good pressure? So we want a heart that is working efficiently. We don't want an underfilled heart. We don't want an overfilled heart. We want a good heart that is filled appropriately and is able to generate a good pressure ultimately. To evaluate that, we should first really look at our Starling curve and review Starling curve. And essentially, your Starling curve is all about stretch. And we should understand the greater the stretch of the myocardium before the systolic side, so in the preload phase, the stronger the ventricular contraction. So we have preload coming in. That gives us the start of that Starling curve, and that really starts the foundation of that overall cardiac cycle. If we evaluate the Starling curve from the standpoint of a graph, you can see that that increased cardiac output versus a decreased cardiac output, and it's all about understanding that overall ability to stretch. It really does start with the preload side, but can also be limited significantly from the afterload side. And that's where you get into those decreased cardiac output zones. If we look specifically at this, you can see A is a normal Starling curve, and you can see that this red line here, and B is that delineation between normal and abnormal where you would have a heart failure. And this is where you start seeing a big increase in left ventricular end diastolic pressure. This is causing a compensatory rise in preload. So the preload is going to try to pick up. We're moving our unstressed volume to stressed volume in an attempt to maintain stroke volume, despite the loss of really prominent inotropy. And so that's really essential, and we're going to evaluate Starling curve as we look at these cases, but to understand that it's all about stretch and how that stretch corresponds with that ending stroke volume. If we start off with just an introduction to the 1 to 5 calculation rule, let's look at a blood pressure. We have a blood pressure of 135/67, very normal. And let's say this patient has a pulmonary artery systolic diastolic of 26/11. So if we first look at what is a normal PA systolic diastolic, Normal PA systolic is going to be 15 to 25. Diastolic is going to be 8 to 15. So that is a great range between the two. And so you can see that we're, I would say, in that normal range. Obviously, the PA systolic is 1 point higher than that high end of normal, but I would say that is completely benign, and every one of us is going to be a little different. So how would we do this? The 1 to 5 rule is essentially looking at the systolic and from the blood pressure and systolic from the pulmonary artery pressure, and you divide those two. So you're going to divide the systolic blood pressure of 135 by the systolic PA pressure, and the ending result should be around that 1 to 5 ratio. And you can see here, we're definitely in that 1 to 5 ratio. So if you take 26 and multiply it by 5, we're going to be right there at that 135. And that is normal. That is what our body and our heart, our advanced hemodynamic parameters should fall into. So from that example, let's look at an example of a patient just for purposes of just that foundation. You can see here we have a CVP of 6. Patient is in a normal sinus rhythm at a rate of 81. We have a pulmonary artery systolic of 25, diastolic of 10, and our blood pressure on this patient is 126/76 with a MAP of 92. Our SpO2 is appropriate at 94%. And so if we look at this, you can easily see that this patient has a 1 to 5 ratio. 126 divided by 25 is 5, or in that range. So let's look at a case study, and we're going to look at 5 different case studies as we go through here and really evaluate what these numbers mean, how we can translate this to an overall understanding of our patient. And really, that's what it's about. It's about making sense of advanced hemodynamic numbers so you can make good clinical decisions and make appropriate medication choices or withhold certain medications that may be poor for that patient and the ultimate outcome of that patient. So we're going to start off with a 78-year-old male. He does have a history of congestive heart failure, really focusing on a diastolic cardiomyopathy. So we have to understand that that means this patient probably has an underlying higher than normal left ventricular and diastolic pressure, and that would be a restrictive cardiomyopathy. If we look at his advanced hemodynamic numbers, patient is in a sinus rhythm at a rate of 93 to 94. CVP is 12. You can see the blood pressure currently is 128/76 with a MAP at 93. But when we add our pulmonary artery pressure to there, notice that we're at 72/58. So that is extremely high. The thing I always teach and tell classes is when you see high pulmonary artery pressure, systolic, diastolic, despite the blood pressure, that always leads you to look at the left side of the heart. That patient has some type of impact on that left ventricle. It could be a systolic, most often a diastolic failure, again, which encompasses a restrictive cardiomyopathy, and that is related to longstanding hypertension over years. So how do we evaluate this patient? Well, if we take this patient and we say, all right, 128 is my systolic, I'm going to divide it by my pulmonary artery systolic of 72. What is that ratio? If we consider treatments in this patient obviously has a diastolic failure, again, restrictive cardiomyopathy. I would assume this patient has a high SVR, obviously an overfilled heart. We need to reduce SVR, and the way to do that is based on medication administration. So there's multiple ways to do this, and if you talk to different physicians, ICU nurses, the way I've handled this in the HEMS industry, I mean, you can go a lot of ways. Nitro is a great way of handling this patient. I think nitro for me is simple. It's easy. It's easy to titrate. Very short half-life. You can, it's simple. You can obviously go to dobutamine. Dobutamine is going to be a great drug that will definitely reduce that SVR. And in this patient, that's really what this drug is used for, is a reduction in SVR, but it also then optimizes inotropes. And then we have milrinone. Milrinone is a drug that's used more so in late-stage CHF patients like this. It's a phosphodiesterase inhibitor. It's a great drug. Works on calcium channels to optimize that inotropy as well, but also reduces SVR. So different options, but ultimately the end result is a reduction SVR, which is going to then allow that heart to improve its overall contractility. If we have all this restriction, all this engorgement, we have a high diastolic pressure. We can't eject the blood out of the left ventricle through the aorta efficiently. And so we need to reduce the upflow pressure and then optimize inotropy to optimize cardiac output. Let's look at case study number 2. In this example, we have a 56-year-old male suffering from just an undifferentiated hypotension at this point, unknown volume status, but does have a past medical history of cor pulmonale and pulmonary hypertension. If we look at this patient's advanced hemodynamic numbers, patient is in a sinus tach at 128. CVP is 3 at this point, 24/10 on our pulmonary artery pressure, and we have a patient that has a hypotensive or a perceived hypotensive pressure. So what I really want to focus on is, number one, look at that blood pressure, 82/54. If you just looked at that, you didn't calculate a MAP. MAP is 63, right? It's below 65, but it's above 60. So, depending on where this patient normally sits blood pressure-wise, if they're in a state of long-standing hypertension and they're sitting higher, then this pressure is obviously potentially symptomatic. But our pulmonary artery, systolic and diastolic, are perfectly normal. So how do we treat this patient? From a standpoint of our ratio, 82 divided by 24, what is that? And that ratio is right at 1:3. If we look at this from the physiology standpoint, we have to understand that when you have a patient with a high pulmonary vascular resistance related to pulmonary hypertension, and you have a right heart that's overwhelmed, you have pipes that are essentially stiff. And this definitely can cause future right ventricular MIs. These patients are going to have right ventricular overload, and really it's going to cause a right ventricular afterload to be increased, which then causes a overall drop in stroke volume and causes a right ventricular coronary perfusion to drop. That wall tension, that right ventricular wall tension then increases, and that causes oxygen demands to skyrocket. That then, can cause some right ventricular stretch. It can cause malformation of the valves. Obviously, we have our tricuspid and our pulmonic valves, and that in high afterload states can cause that septum to actually shift, which impedes on that left ventricular preload and overall stroke volume, and a lot of times will actually cause stroke volume to decrease. So, it's really important to understand how we treat these patients. Things we want to avoid, we want to really be careful with fluids. I think we really get enamored on optimizing preload, but remember, this patient has a high preload. That's the problem. They're overfilled on the right side. So we have to be careful on the fluids. We want to increase our overall ratio ultimately. So medications that we want to avoid would be phenylephrine, for example. Phenylephrine we know will increase both PVR and SVR. And really the ultimate goal is to make that ratio widen. We want a widened ratio. And so we can do one of two things. We can drop our pulmonary vascular resistance, or we can increase our SVR, or we can do both. We can drop our PVR, raise our SVR, but ultimately that's our ultimate goal. Vasopressin would not be advisable as well. That's going to just increase SVR. It will not increase PVR. Another treatment to avoid would be obviously dobutamine. Dobutamine is going to drop SVR. We need to raise SVR, or we need to drop our PVR. Amilrenone will also drop our SVR. So how can we treat this patient? Obviously, we need to support that SVR. We need to widen the gradient between those two pressures. So our right-sided pressure versus our left-sided pressure needs to be widened. We definitely don't want those to come closer together. Some treatment considerations to look at would be on the PVR side. You could always try inhaled pulmonary vasodilators. This is going to be obviously based on your guidelines or protocols. Flolan is an example that would be really good in this situation. Nitric would be excellent. Nitroglycerin, inhaled nitroglycerin would be a great option. Even some inhaled milrinone would work great on that right side. Now let's look at case study number 3. In this example, we have a 47-year-old male. And let's just give an example that this patient was given a medication error of phenylephrine. So we'll just say either an incorrect dose or an excessively high dose. And when we look specifically at their advanced hemodynamic numbers, we have a blood pressure that is really high at 210/117. Patient is in a sinus rhythm at 82. CVP is elevated at 14. And our pulmonary artery pressures are also elevated at 47/27. But if you do the math here, that's the thing to consider. If you do the math and you divide, we have our systolic of 210 and you divide that by 47. So in this example, the ratio is 1 to 4.5. Not perfect, but I would say that is pretty darn close. And this is a great example of, even though we have a very high excessive medication administration in this example, it caused a big jump in that blood pressure. Really, unless you're seeing any ischemic processes, I would definitely do a 12 lead on this patient, look at their past medical history, make sure that you don't have any issues with ischemic processes. Really, this is a watch and see patient. Healthy heart, Starling curve is going to be still normal, but I would watch that ratio, and this is an example that the ratio matches out. Heart rate stayed fairly normal, blood pressure goes up significantly, and PA, systolic and diastolic, go up accordingly in that normal ratio. Case study number 4. This is a 36-year-old female patient, aspiration secondary to ETOH toxicity, really suffering from profound hypoxia. This is an example, as we're going to see, where SpO2 doesn't really match our ABG numbers. PaO2 is 42, but we're in a sinus TAC right around 100, 101, CVP of 13. Notice this patient is hypotensive, 78/44 with a MAP of 55, definitely not perfusing the kidneys. And we have a corresponding pulmonary artery pressure of 59/40. So what's going on in this patient? Well, really, starting out, we know we need to optimize both preload. That's going to optimize afterload. We have a dilated heart. We have a heart that is starving. Our Starling curve is definitely flat in this example, but the heart, remember, is lacking glucose. It's lacking oxygen, and really based on that poor pH status that this patient is having, this heart is under a huge stress load. And that is really, really difficult. So how are we going to treat this patient? Obviously, we need to fix the hypoxia. This patient needs to be managed with advanced airway management. This patient is already intubated, good vent settings, pulmonary toilet, really focusing on optimizing that oxygenation. But we have to remember that delivery of oxygen, DO2, is equal to the content of oxygen in our arterial blood, CaO2, multiplied by perfusion or cardiac output. And so we have to make sure we also fix perfusion. This patient has a hypotensive blood pressure, very, very low MAP, not perfusing the kidneys. So definitely levofed administration would definitely be a gold standard. I would even consider going with vasopressin as a second line vasopressor, but we need to optimize that SVR and really focus on every aspect of stroke volume in this patient. But ultimately, Starling curve is also affected significantly by that hypoxia. And so that Starling curve is definitely flat. Let's do one more example. And this is a hemodynamic pearl. This is something that really there's not a ton of literature on. This is more of an application that has been taught from person to person, clinician to clinician, physician to physician. And it is based on really the concept and understanding that PEEP impacts our advanced hemodynamic numbers. So do we really understand what we're seeing based on a patient on higher PEEPs? And those numbers really that are going to be a focal point would be all of them. Our CVP, central venous pressure, our pulmonary artery systolic, diastolic, and if we were to actually do a wedge pressure and wedge that catheter, as I said previously, really looking at the diastolic PA gives us the same information. Here's an example. 43-year-old female, COVID-19 positive, currently in ARDS and secondary sepsis. And so if we look at the vent settings on this patient, they have her on a mandatory rate of 12. We'll say frequency is, right around 20. She is overbreathing the vent a little bit. And PEEP is 15, tidal volume of 500. So they're using lung protective strategies. 100% FiO2. If we were to look at this patient and evaluate her hemodynamic status thoroughly, number one, let's start with the blood pressure. We have 82/58. And if we were to not even look at the map, it'd be very easy to get focused in on that blood pressure and try to increase that. We might give excess fluid, but really that's the importance of looking at the big picture, and that is evaluating that map. This patient is in their 40s. If this patient has no past medical history, no hypertension, no other underlying conditions, a MAP of 66 is not terrible in a patient that's COVID positive, sepsis, with ARDS. I'm not terribly upset with that. Obviously, she may benefit from a higher MAP, but that's a pretty good starting point. If we do a corresponding relation and look at that heart rate is higher, right? She's in a sinus tach at 127, narrow complex. So she is compensating like we would expect. Patient has advanced hemodynamic numbers available. Pulmonary artery catheter is placed. They are transducing both the CVP and they're getting their pulmonary artery systolic and diastolic. So if we look at these numbers and evaluate them, from a standard application standpoint, we've always taught very loosely, and it's taught mainstream medicine, that a CVP is an indication of preload. And I think that really from the standpoint of real patient application, I don't really think that's too very true. I think there's some fallacy there. I think there's a lot of factors that impact that CVP. And I think there's definitely evidence that says that if you make that CVP higher and higher, you're actually causing a bigger problem. And I don't think it warrants really driving that CVP up. When we look at the PA systolic and diastolic, 26/14, well, heck, that is right where we need to be. Those are normal parameters. And so how do we glean information from that? We have an end-tidal CO2 at 22. It is low. Remember the 3 Ps of end-tidal CO2, and really I would focus on the perfusion status first, which we definitely have a lower blood pressure. MAP is 66 though, and so is that CO2, end-tidal CO2, an indication of a partially compensated metabolic acidosis? And I would probably most likely say that it is. It's either perfusion and that acid-based disorder. SpO2 at 90%, not terrible. Again, probably a little hypoxic, but remember that SpO2 is not a true reflection of what's happening at the tissue level, so we would need to evaluate this patient in other ways. Remember, she's most likely a right shift on the oxyhemoglobin curve, and that is going to make it to where her hemoglobin affinity for oxygen is poor. Her saturation, the seats at the table, are not going to be filled with SpO2, with oxygen molecules, I should say. And so you're definitely going to have a lower SpO2 in comparison with a PaO2. But ultimately, we need to do an ABG, look at the SaO2 and PaO2, and evaluate the patient from that standpoint. But where I'm getting at with this section is, are these numbers really a reflection of what's going on? Remember, this patient was on 15 at PEEP, and we have to remember that PEEP impacts interthoracic pressure significantly. You can simply do this with a test lung. Put a test lung on 5 of PEEP and look at the exhale tidal volume that you're getting. And then simply turn the PEEP up to 15 and look at the impact on that exhale tidal volume. It is profound, and that's volume that is then trapped in the alveoli at the end of exhalation. So that is definitely going to have an impact on your advanced hemodynamic parameters. And so that's where we get into, again, looking at the half PEEP rule. And the rule is simply this: take whatever PEEP the patient is on and divide it by 2. Take that amount and you subtract it from each of these hemodynamic numbers. So in this example, we subtract half of 15. We'll just say we'll round it down to 7, easy math. Our CVP is actually 2 in this example. If we look at our PA systolic diastolic, it's actually 19/7. So is this patient as stable from an advanced hemodynamic parameter status as we thought? And I would definitely say absolutely not. This patient definitely needs to have a little bit more aggressive preload and afterload optimization with pharmacology. We probably need to evaluate overall volume status and make sure this patient is treated accordingly. And that is a great example of how PEEP can cause us to have a false impression of our numbers. So again, half PEEP rule, take the PEEP, divide it by 2, take that remaining amount and subtract it from your CVP, your PA systolic diastolic. You can also do that from your wedge pressure if you were to do that. Again, I don't feel like there's ever a reason. In summary, guys, advanced hemodynamic numbers can be hard to master. They can be very overwhelming. A strong understanding of the different shock states will give you a great foundation. I can't stress that enough. You got to understand the foundation, the physiology. The 1 to 5 rule is a great way of dissecting the relationship between the blood pressure and the pulmonary artery systolic diastolic and the parameters and how we relate that back to overall treatment. Remember, PEEP will have a great impact on your numbers. Remember the half PEEP rule, and that is to take your PEEP and divide it by half, then subtract that from your advanced hemodynamic numbers, which include your CVP, your pulmonary artery systolic, diastolic, and pulmonary capillary wedge pressure. And guys, that's all I have. I hope this was enlightening. I hope this was a good educational podcast. If you have any questions, please email me at eric.bauer@flightbridgeed.com, and I will talk to you soon.